Uncommon causes of pustules. Coccidioidomycosis. Coccidioidomycosis is a rare deep fungal infection presenting with skin manifestations. It is caused by the dimorphic fungus, Coccidioidomycosis. Most cases result from the inhalation of spores with subsequent dissemination to the skin and other organs. Immunocompromised patients, especially HIV-infected individuals, are at highest risk. Clinical features of most deep fungal infections, including blastomycosis, are initial formation of pustules, plaques, and nodules evolving into verrucous plaques. Biopsy and tissue culture confirm the diagnosis. Coccidioidomycosis, large verrucous plaque with pustules. Dermatophyte, Kerion. Dermatophytes can infect hair follicles and may result in pustules. This condition is sometimes confused with bacterial folliculitis. A Kerion is a dermatophytic infection, frequently of the scalp, that appears as an indurated, boggy, inflammatory plaque studded with pustules. Kerions are frequently confused with bacterial pyodermas. The most common organism causing a Kerion is Trichophyton rubrum. Systemic antifungal therapy is necessary. Dermatophyte. A. Pustules infecting hair follicle, culture necessary for the diagnosis. B. Kerion, a boggy plaque representing severe immunologic reaction to dermatophytes infecting hair follicles. Gonococcemia. Gonococcemia, gonococcal arthritis, dermatitis syndrome, represents a systemic infection characterized by fever, arthralgia, tenosynovitis, septic arthritis, and hemorrhagic or purpuric pustules. The hemorrhagic pustules appear in an acral distribution and are few in number. The disease results from the dissemination of gonococci from an infected mucosal site. Diagnosis is confirmed by a bacterial culture of the affected mucosal site. Treatment is with intravenous or intramuscular antibiotics, most commonly ceftriaxone. Gonococcemia, few hemorrhagic pustules in characteristic acral distribution. Subcorneal pustular dermatosis. Sterile pustules are the hallmark of subcorneal pustular dermatosis. The disease is characterized by annular or expanding, polycyclic collections of pustules on a red base. Flexural accentuation is common. The disease has a waxing and waning course. Monoclonal gammopathies have been reported with this condition. Skin biopsy confirms clinical suspicion of the disease. Dapsone is the treatment of choice. Subcorneal pustular dermatosis. Annular plaque studded with pustules in the axilla, flexural location is characteristic.
Case 1, pustules and papules surrounding an ulcer. This 38-year-old woman was receiving wet dressings for her leg ulcer. After 1 week, a rash developed around the ulcer. Describe what you see. Surrounding the ulcer is a pink, slightly scaling patch with satellite pustules and papules. What is your differential diagnosis? The differential diagnosis includes contact dermatitis from the medications used in the dressings. However, with the satellite pustules and papules, candidiasis also needs to be considered. What is the first diagnostic test you would do? The first diagnostic test should be a KOH examination of a scraping from the border of the lesion. In this patient's case, it was positive for hyphae. It is difficult to distinguish microscopically between candidal and dermatophytic hyphae, but the clinical picture favors candidiasis. How would you treat it? Local therapy with a topical imidazole cream applied sparingly twice daily, and discontinuation of the wet dressings resulted in prompt clearing of the eruption.